We are going to discuss peripheral neuropathy. I am Dr. Paridhi Shivde. I am author of the books like Art of Clinical Medicine and Clinical Examination, which are available on Amazon.com and Amazon.in. What are the symptoms of peripheral neuropathy? Symptoms may be sensory, motor, autonomic, or mixed. Most common are sensory symptoms. What are sensory symptoms? Sensory symptoms like paresthesias. There is tingling sensation, pins or needle sensation, feeling of numbness sensation or burning sensation. Then allodynia. Allodynia is non-painful stimulus is perceived as painful. For example, a simple touch is perceived as pain. Dysthesias are spontaneous painful sensations without any stimulus. Loss of sensation to pain or to touch. There may be sensory ataxia, that is loss of joint position sense causes difficulty in maintaining the posture and walking, causing sensory ataxia. These symptoms usually start in the longest nerves in the body and so first affect the feet and later the hands. This is called stocking glove pattern. First pick there is mononeuropathy multiplex, that is single nerves are involved at multiple sites, that is mononeuropathy multiplex. And in second pick there is polyneuropathy in glove stocking pattern, like it first starts in feet and slowly it ascends up, and it then also involves upper the hands, like in the distribution where a person wears gloves and stocking. So these sensory symptoms are known as glove stocking pattern in polyneuropathy. Motor symptoms. There can be muscle cramps, fasciculations, and motor weakness. Autonomic symptoms. Orthostatic hypotension or lightheadedness, heat intolerance. There may be increased or decreased sweating. GIT symptoms like gastroparesis, postprandial bloating, chronic diarrhea, or constipation. Genitourinary dysfunction like erectile dysfunction, impotence, or urinary incontinence. Orthostatic hypotension. To check for orthostatic hypotension, patient is made to lie down for around 5 minutes and then blood pressure and pulse is taken. Then the patient is said to stand up and again blood pressure and pulse rate is measured 1 minute and 3 minutes after standing. So by definition, orthostatic hypotension is sustained systolic blood pressure drop of 20 mm of mercury or more, or diastolic blood pressure drop of 10 mm mercury or more within 3 minutes after standing. Symptoms of orthostatic hypotension are lightheadedness, tiredness, decrease in concentration, blurred vision, anxiety, palpitation, and nausea. On examination, there may be lower motor neuron type of weakness in peripheral neuropathy. Cranial nerves may be involved. In motor examination, there may be bilateral foot drop. In nutrition, there is atrophy of the muscles. In muscle tone examination, tone is decreased or absent. Muscle power, there is weakness. Sensory examination, temperature and touch sensations are lost, mainly distal symmetrical. Vibration sense and joint position sense are lost, mainly distally. Reflexes are decreased or absent. And in plantar reflex examination, there is no response. What is the etiology or causes of peripheral neuropathy? Infections, HIV disease, cytomegalovirus, syphilis, leprosy, diphtheria. Immune-mediated causes, that is GBS. GBS is also known as AIDP, that is acute inflammatory demyelinating polyneuropathy, and CIDP, that is chronic inflammatory demyelinating polyneuropathy. Metabolic causes like diabetes mellitus, chronic renal failure, vasculitis, polyarteritis nodosa, Sjogren's syndrome, SLE, rheumatoid arthritis. Other causes are toxins like alcohol, drugs used in HIV like stavudine, anti-cancer drugs cisplatin, vincristine, placitaxel, other drugs like isoniazid, ethambutol, dapsone, toxins like arsenic, lead, mercury. Nutritional causes like vitamin B6 deficiency, vitamin B1 deficiency, vitamin B12 deficiency, vitamin E and copper deficiency. Excess of vitamin B6 or B6 toxicity can also lead to peripheral neuropathy. Other causes are hereditary. Most common is Charcot-Marie tooth disease. Cancers can cause paraneoplastic neuropathy. Hypothyroidism and trauma can also cause peripheral neuropathy. Then last is idiopathic or cryptogenic sensory polyneuropathy. When on extensive evaluation no cause is found, then it is known as idiopathic or cryptogenic sensory polyneuropathy. Out of all these causes we have discussed, most common causes of peripheral neuropathy are diabetes mellitus, chronic alcoholism, nutritional deficiencies like B1 deficiency, B6, B12 and vitamin E deficiency, chronic kidney disease, hypothyroidism. Few words about Guillain-Barré syndrome or acute inflammatory demyelinating polyneuropathy, polyradiculoneuropathy, AIDP. It is immune mediated. It is a polyradiculoneuropathy characterized by acute onset areflexic, predominantly motor weakness, progressing in an ascending manner. Albuminocytological dissociation in CSF is found, that is, albumin is raised and cytology, that is, cell count is normal. Demyelination is found in nerve conduction study. Chronic inflammatory demyelinating polyneuropathy, CIDP. It has similarities to AIDP, like it is progressive, symmetrical, proximal and distal weakness of limbs. There is albuminocytological dissociation in CSF and demyelination is seen in nerve conduction study. But it has chronic course. AIDP has acute onset and CIDP has chronic course. An acute onset of CIDP is considered when a GBS or AIDP deteriorates more than 9 weeks after onset or relapse at least 3 times. Treatment is done with IV immunoglobulins, plasmapheresis or steroids. Patients who don't respond to above therapy, then immunosuppressive drugs like azathioprine, methotrexate or cyclophosphamide can be added. Few words about diabetic neuropathy. Most common type of diabetic neuropathy is DSPN, that is distal symmetrical polyneuropathy. Then diabetic autonomic neuropathy, diabetic mononeuropathies and multiple mononeuropathies. Most common diabetic mononeuropathy is carpal tunnel syndrome, others are tarsal tunnel syndrome, meralgia paresthetica. Cranial neuropathies can be present. Most common cranial nerve palsy is 7th cranial nerve palsy, followed by 3rd, then 6th, and less frequently involved is 4th cranial nerve. Diabetic radiculoplexus neuropathy or diabetic amyotrophy or Bruns-Carland syndrome. Diabetic amyotrophy. It is present in 1/3 of the diabetes mellitus patient. There is severe pain in lower back, hip and thigh in one leg unilaterally. atrophy and weakness of proximal and distal muscles in affected leg within few days or weeks. Weakness progresses for 18 months or more. Subsequently, there is slow recovery, but there is residual weakness, sensory loss, and pain in many patients. HIV-associated peripheral neuropathy. There may be a variety of neuropathies found in HIV disease. There may be distal symmetrical polyneuropathy, DSPN, inflammatory demyelinating polyneuropathies like GBS or AIDP and CIDP. Multiple mononeuropathies can be there in vasculitis and cytomegalovirus related infection present in HIV. Polyradiculopathies, which is common in HIV-related CMV infection. Autonomic neuropathy are also present. Toxic neuropathies due to some drugs and toxins. Metronidazole, chloroquine or hydroxychloroquine, amiodarone, dapsone, nitrofurantoin, pyridoxine, vitamin B6, isoniazid, ethambutol, phenytoin, lithium, lead, mercury, arsenic. All this can also cause peripheral neuropathies. Few words about neuropathy associated with malignancy. Either it can be due to direct effect of cancer by invasion or compression of the nerves. Then it can be due to toxic effect of the treatment or drugs. Then there is remote or paraneoplastic effect. There can be paraneoplastic neuropathy, and most common cause is small cell carcinoma of lung. Other causes are breast cancer, gynecologic and hematological tumors. Symptoms like asymmetric numbness and paresthesias in distal extremity, loss of proprioception leading to sensory ataxia. There is presence of antibodies against anti-neuronal nuclear antibodies. Example, anti-U antigen antibodies in serum or CSF. Hereditary sensory motor neuropathy. Most common type is Charcot-Marie tooth disease. There is genetic transmission and it is slowly progressive. It starts in first and second decade. Present with distal leg weakness, foot drop. There may be foot deformities. As compared to acquired neuropathies, no sensory symptoms are present. There is no medical treatment, but physical and occupational therapy may be beneficial. In first pic, there is inverted champagne bottle leg sign, looking like inverted champagne bottle. Then in second pic, it is there is we can see in the foot there is lack of muscles, a high arch and hammer toes present in Charcot-Marie tooth disease. How to approach peripheral neuropathy? We have to approach peripheral neuropathy, and this 7 key questions should be asked or examined. What system are involved, whether it is motor, sensory, autonomic or combination. What is the distribution of the weakness, only distal or proximal and distal, focal or asymmetrical versus symmetrical. What is the nature of sensory involvement, temperature loss or burning or stabbing sensation, stabbing pain as in small fiber neuropathies, vibratory or proprioceptive loss, causing sensory ataxia as in large fiber neuropathies. Is there evidence of upper motor neuron involvement? What is the temporal evolution? Is it acute, days to 4 weeks, subacute, 4 to 8 weeks, or chronic, persisting more than 8 weeks? Then we have to ask, is there any evidence of hereditary neuropathy, family history of neuropathy, lack of sensory symptoms despite Sensory signs. Are there any associated medical conditions? Should be inquired like cancer, diabetes, connective tissue diseases, or other autoimmune diseases, infections like HIV, Lyme disease, leprosy. Medications including over-counter drugs that may cause toxic neuropathy should be inquired. Preceding events, any drugs intake or toxin intake should be inquired. Nature of sensory involvement should be examined or asked. Small fiber neuropathy, which are known as painful neuropathy. Small fibers transmit pain and temperature. Most common cause is diabetes mellitus, then leprosy, amyloidosis, Sjogren's syndrome, and paraneoplastic syndrome. Large fiber neuropathy, also known as ataxic neuropathies. Large fibers conduct proprioception and vibratory sensation to brain. Example, most common example is vitamin B12 deficiency. Then cisplatin, an anti-cancer drug, and pyridoxine toxicity. Which system is involved? Motor, sensory, autonomic, or mixed? Motor system is predominantly involved in GBS or AIDP, in hereditary motor sensory neuropathies, in lead poisoning, and in diphtheria. Sensory involvement is more common in diabetes, vitamin B12 deficiency, toxicity with cisplatin, pyridoxine toxicity, carcinoma, and HIV disease. Autonomic neuropathies are present in GBS, diabetes mellitus, amyloidosis, and paraneoplastic disease. Mixed symptoms are present usually in diabetes mellitus, hereditary neuropathies, and paraneoplastic syndromes. Distribution. Whether it is mononeuropathy, polyneuropathy, or mononeuropathy multiplex. Mononeuropathy is single peripheral nerve is involved. Polyneuropathy is widespread symmetrical distribution of peripheral nerves. Mononeuropathy multiplex, that is multiple separate non-contagious more than two peripheral nerves are involved simultaneously or sequentially. Mononeuropathy. Causes are entrapment neuropathies like entrapment or compression neuropathies by myxedema, rheumatoid arthritis, amyloidosis, and acromegaly. Trauma can cause mononeuropathy, single nerve involvement. Ischemic lesions like diabetes mellitus, vasculitis, leprosy, neoplastic infiltration of the nerve, hereditary neuropathies with pressure pulses. Few mononeuropathies. Most common of this is carpal tunnel syndrome due to involvement of median nerve. There is pain, numbness, and paresthesias in finger, and on examination there is sensory loss in thumb, index, and middle finger. Tarsal tunnel syndrome is due to involvement of posterior tibial nerve. There is pain, numbness, and paresthesias in the sole of the feet but not the heel. On examination there is sensory loss over sole. Radial nerve involvement at a spinal groove causes wrist drop. On examination, there is wrist drop and fingers and thumb extensors are paralyzed. Involvement of peroneal nerve at fibular head causes foot drop, and on examination there are weak dorsiflexors and inversion of the foot is weak. Last is meralgia paresthetica, where lateral femoral cutaneous nerve is involved at the inguinal ligament. And there is pain, numbness, and paresthesias typically at the anterior lateral thigh. And on examination, there may be sensory loss at the same site. Polyneuropathy. Causes are diabetes mellitus, nutritional deficiencies B1, B12, and Guillain-Barré syndrome. Mononeuropathy multiplex. In diabetes mellitus, vasculitis, due to SLE, Sjogren's syndrome, polyarthritis nodosa, and rheumatoid arthritis, due to infections like HIV disease or cytomegalovirus infection, and it can be due to leprosy. Distribution of weakness, whether it is distal, proximal and distal, whether it is symmetrical or asymmetrical. Distal weakness is seen in polyneuropathies. Both proximal and distal weakness is seen in Guillain-Barré syndrome or AIDP. Symmetrical weakness in polyneuropathies and GBS. Asymmetrical weakness in radiculopathies, which may be unilateral, plexopathies, compressive mononeuropathies, and mononeuropathy multiplex. Neuropathy with upper motor neuron involvement. It is seen in most commonly in the vitamin B12 deficiency. It may also be present in copper deficiency, HIV disease, and severe hepatic disease. Few words about differentiating between demyelination and axonal neuropathies. Typical example of demyelination neuropathy is Guillain-Barré syndrome or AIDP, that is acute inflammatory demyelinating polyneuropathy. And axonal example is diabetes mellitus. Pattern in demyelinating neuropathies, proximal and distal weakness both is present. In axonal neuropathies, distal weakness is predominant and more than the proximal weakness. Onset is acute or subacute in demyelinating and it is slow in axonal. Symptoms, there may be paresthesias and weakness in demyelination, and in axonal there is paresthesias plus distal weakness. In sensory signs examination, vibration and proprioception are involved more in demyelination, and in axonal, pain and temperature is involved more than vibration and proprioception. Motor examination, motor weakness is present in proximal and distal, and in axonal, it is mainly there is distal weakness. Reflex examination, areflexia in demyelinating diseases, and in axonal there may be distal areflexia. On nerve biopsy examination, there is demyelination and remyelination in demyelinating neuropathies, and axonal degeneration and regeneration is seen in axonal neuropathies. In nerve conduction study, velocity is affected more than amplitude in demyelinating, and in axonal neuropathies, amplitude is affected more than velocity. Prognosis, demyelination, it is rapid recovery. In axonal neuropathies, there is slow recovery. How to diagnose? By clinical examination and investigations. Investigations like complete blood count, ESR, renal function tests like urea, creatinine, liver function tests like SGOT, SGPT, bilirubin, albumin, alkaline phosphatase, prothrombin time, vitamin B12 level, folate level, fasting blood sugar, HbA1c, oral glucose tolerance test, OGTT. How OGTT is performed? The fasting sample should be taken and the time point should be noted. The patient should then consume the correct amount of glucose established by weight, that is up to 75 grams, over a period of 5 minutes. Additional samples should be taken at 30 minutes, 60 minutes, 90 minutes and 120 minutes time points. And results of OGTT, there may be normal result, impaired result and abnormal or diagnostic result. In impaired results, fasting blood sugar between 100 to 125 mg per deciliter, 2-hour glucose level between 140 to 200 milligram per deciliter. In diagnostic or abnormal result for type 1 or type 2 diabetes mellitus, fasting blood sugar more than 126 milligram per deciliter and 2-hour glucose level more than 200 milligram per deciliter. Other investigations like RA factor, ANA, anti-dsDNA, anti-Rho, anti-La antibodies, thyroid function tests like T3, T4, TSH, HIV testing, toxin profile testing for mercury, lead or arsenic poisoning, antibodies in CSF like GM1 and GD1A. CSF examination can be done for albuminocytological dissociation in GBS or AIDP and CIDP. Anti-neuronal nuclear antibodies, example anti-U antibodies in paraneoplastic syndromes. Nerve conduction study to confirm neuropathy, to know whether it is mononeuropathy multiplex, radiculopathy, plexopathy or generalized polyneuropathy. Whether it is sensory, motor, autonomic or mixed, and whether it is axonal or demyelinating. Normal NCV, demyelinating and axonal. In demyelinating, there is nerve conduction velocity is slow, but action potential is normal. In axonal, there is reduced action potential, but nerve conduction velocity is normal. Nerve biopsy. It should be done if there is suspected vasculitis, leprosy or CIDP. And it is done only when nerve conduction study is found to be abnormal. And most common nerve that has to be biopsied is sural nerve at the ankle joint. Despite an extensive evaluation in half of the patients, that is 50% of the patients, no etiology or cause is found. But patients typically have predominant sensory polyneuropathy, and it is labeled as idiopathic or cryptogenic sensory polyneuropathy. How to manage peripheral neuropathy? If a person has diabetes mellitus, this strict glycemic control should be managed. Strict glycemic control should be targeted. Vitamin B12 deficiency, vitamin B12 replacement is given. In hypothyroidism, thyroxine is given. In vasculitis, immunosuppressive drugs like azathioprine, cyclophosphamide is given. Immune-mediated GBS, IV immunoglobulins or plasmapheresis can be done. In CIDP, IV immunoglobulins, plasmapheresis and immunosuppressive drugs can be given. In entrapment neuropathies, to relieve the compression, surgeries can be done. Treatment of painful sensory neuropathies by drugs. First line drugs used are tricyclic antidepressants, amitriptyline and nortriptyline, gabapentin, pregabalin and duloxetine. Other drugs used for painful sensory neuropathies are carbamazepine, phenytoin, venlafaxine and tramadol. Local cutaneous application by lidocaine cream or capsaicin cream. For neuropathic pain in peripheral neuropathy, US FDA has approved pregabalin and duloxetine. Few words about treatment of orthostatic hypotension. Non-pharmacological treatment like lifestyle modifications such as avoiding sudden postural changes, and patient is suggested to Sit on the edge of the bed for around 5 minutes before standing. Calf muscle exercises. Drinking 2 liters of fluid per day. Raising the head of the bed to 15 to 20 degrees. Using elastic compression stockings. Medications used are fludrocortisone 0.1 mg per day to 0.3 mg BD, midodrine 5 to 10 mg TDS, and erythropoietin subcutaneous injections. A few multiple choice questions. A patient is on anti-tubercular therapy. Which of the following vitamin is used to prevent the development of peripheral neuropathy in that patient? B5, B1, B12 and B6. Answer is vitamin B6. Sensory motor neuropathy may be caused by all of the following except diabetes mellitus, lead poisoning, arsenic poisoning and isoniazide. Answer is lead poisoning. Lead poisoning causes predominantly motor neuropathy. Which of the following is a first-line drug used in the treatment of painful diabetic neuropathy? Among all these drugs, carbamazepine, valproate, duloxetine and venlafaxine. Answer is duloxetine. Most common type of hereditary neuropathy is Tangiers disease, Friedreich ataxia, Charcot-Marie-Tooth disease, familial amyloid polyneuropathy. Answer is Charcot-Marie-Tooth disease. All of the following causes small fiber neuropathies except vitamin B12 deficiency, HIV induced, Hansen's disease and amyloidosis. Answer is vitamin B12 deficiency, which causes large fiber neuropathy or ataxic neuropathies. Peripheral neuropathy can impair 1. Sensory function, 2. Motor function, 3. Autonomic function. First answer is 1 or 2 only. B is 1 and 3 only. C is 2 and 3 only. And D is 1, 2 and 3 all present. Answer is peripheral neuropathy can cause all type of symptoms, motor, sensory or autonomic, either single or in combinations. Symmetric proximal and distal weakness is the hallmark of acquired immune demyelinating polyneuropathies, that is AIDP, amyotrophic lateral sclerosis, mononeuropathy multiplex, and all of the above. Answer is symmetrical proximal and distal weakness is seen in AIDP or GBS. All of the following are associated with autonomic neuropathies except diabetes, acquired amyloidosis, hyperthyroidism, porphyria. Answer is hyperthyroidism. Which of the following is the most common type of neuropathy seen in diabetes? Radiculoplexus neuropathy, mononeuropathies, autonomic neuropathies, and distal symmetrical sensory and sensory motor polyneuropathy, that is DSPN. Answer is distal symmetrical sensory and sensory motor polyneuropathy is most commonly seen in diabetes. Most common malignancy causing neuropathy is carcinoma lung, carcinoma breast, carcinoma ovary or carcinoma stomach. Answer is carcinoma lung. Which of the following are elevated in CSF in a patient with Guillain-Barré syndrome or AIDP? Lymphocytes, leukocytes, glucose and proteins. Answer is proteins. There is albuminocytological dissociation found in CSF. That is, albumin or protein is raised and cell count is normal. When chronic inflammatory demyelinating neuropathy, that is CIDP, is suspected. Out of this, one is the answer. One is a GBS deteriorates for more than 5 weeks after onset or relapse at least 3 times. Second is a GBS deteriorate more than 5 weeks after onset or relapse at least 2 times. Third is a GBS deteriorate more than 7 weeks after onset or relapse at least 2 times. And fourth is a GBS deteriorates more than 9 weeks after onset or relapse after at least 3 times. And answer is CIDP is considered usually when GBS deteriorates more than 9 weeks after onset or there is relapse at least 3 times. Large fiber neuropathy present as proprioceptive loss, stabbing pain, temperature loss or burning sensation. Burning pain. Answer is proprioceptive loss. Thank you. Please like, share and subscribe.